introduce RS 0157, which enacts the Women's Bill of Rights.
Committee, any objections to this being a committee bill? Seeing none, thank you. Do we have any other requests for bill introductions? Yes.
Good morning, Madam Chair, members of the committee. My name is David Fye. I'm the Executive Director for the Behavioral Sciences Regulatory Board, and we would request introduction of a bill with the RS number 0773. It's a bill that concerns the BSRB and has several changes to licensure statutes. It would create several new different types of temporary licenses and do several other items in statute for the professions that we regulate.
Thank you, committee. Any objections to this being introduced into the committee? Yes.
This is just an informational question. So is it all of them or just specifically social workers or?
There's 7 professions we regulate, so there would be a new type of temporary license for the social work profession. There's also a student type of temporary license for addiction counseling. So it kind of varies by profession.
Thank you.
Thank you, David. Committee, this morning we have a presentation by Linda Mowbray, President and CEO of the Kansas Healthcare Association and Kansas Center for Assisted Living. Linda, welcome to committee.
Thank you, Madam Chair. I am Linda Mowbray, Kansas Healthcare Association, Kansas Center for Assisted Living, and I'm very pleased to be here today. The Kansas Healthcare Association and the Kansas Center for Assisted Living, we're a trade association. So we represent the profession, the trade of nursing homes, assisted living, home plus, residential health care, and other senior services across the state. We've been around since 1951, and we have a membership of about 260 member buildings. Today, I'd like to give you a little bit of a briefing and overview on the state of our long-term care profession here in Kansas. The first thing I'd like to do, if I can turn your attention to page 3 of your PDF file, and that begins the classifications of adult care homes. Adult care homes is a very broad-based term that includes things like adult daycare, nursing homes, assisted living, residential health care, home plus. Each of those have their own definitions. The next page, you will find that I've outlined for you in a little grid who pays for what and who is regulated by whom. And that information can be really helpful when we start talking about Medicaid versus Medicare versus private pay, whether CMS is regulating you or whether you're being regulated by just the state agency. And, you know, I'm always available to try to answer any questions or clarify if we have that point. The next page that we have for you, it would be page 5. You also have a laminated version of that page. Those are the commonly used acronyms, which we can throw out all over the place and you sit there with your head swirling. So first of all, if any of us do throw out an acronym that you are not familiar with, please stop us and we'll try to explain. But as a handy reminder, when you get back to your office or if you're reviewing committee notes, that's a good little reference sheet to go up. You are welcome. They stay a little fresher that way. The next area I'm not going to spend a lot of time on. It is considered a risk map. This was done by AHCA back in April of 2022. And that is showing us on page 6 that the nursing homes in Kansas are in trouble. 51% at that time were not sure they could keep working, not sure they could keep operating, not sure they had the staff to take in new residents. And that leaves us with the question of, so where do our seniors go when they can't be in assisted living, when they can't be in their own home. Nursing homes are closing. And with that, I will ask you to skip forward to page 11 of your handouts. And that's the sheet. And it's a very frightening sheet. Those are the nursing homes that have closed in Kansas since 2020. The one in red is one that we know that is closing this March. What that represents is over 1,000 nursing home beds lost. In addition to that, there are many homes that have decertified beds. There are many homes that are not taking new admissions. The root cause of that? Staffing. We do not have the workforce that wants to come to work in long-term care, and we have to change that. Long-term care is a passion. Working with the elders is a passion. When I graduated from college, 87, my first job was in a nursing home. And I wasn't going to stay there too long because, you know, nursing home. 14 years later, I knew that I had found where I belong. And then I had the opportunity to come to work for the Nursing Home Association and amplify the voice of those residents and those staff members. What we have to do is get people in the door. Some will never take to it. Some, like me, will fall in love with the profession and say, this is where I belong. But we have to give them a chance. And we can do that through opening up some regulations, changing the dynamics of how training is done, having those internships, having those apprenticeship programs, having those abilities to expose people to the elderly. The next page does just outline what is on your map, and those are the actual facilities, the names of the facilities that have closed. On page 13, you're going to find the American Healthcare Association jobs report. And if I didn't say this before, Kansas Healthcare Association is part of a federation, which American Healthcare Association is our national arm. And some of you may be familiar with Mark Parkinson. He is the CEO of the American Healthcare Association, so we're very fortunate for that. Of all the sectors in healthcare, long-term care has lost the most employees. And while other sectors are starting to bounce back, and some are even back to where they were staffing-wise, or pretty close, long-term care is not bouncing back. We are not getting our staffing back up. What that means across the state, I've talked about closures. I mentioned decertifying beds, which really just lessens the capacity in a particular area. And I also mentioned hospital admissions, that we're not taking new admissions in many places. That puts a strain on the whole healthcare system. When you have people in acute hospital beds that don't need to be there anymore, but there's no place else to go, that individual, by no fault of their own, is taking up a bed that might be needed for somebody that's had a heart attack or a stroke or some other critical need. So our nursing homes serve lots of different communities, lots of different people for lots of different reasons. But when they can't take new admissions, it does affect the whole system. The last handout that I have in here is a member survey that my colleague Rachel Monger with Leading Age Kansas will go over for you. That is kind of the boots on the ground as to what's happening today in Kansas. You know, staffing is a huge issue, but funding's a big issue too. And the governor's budget has not asked for the amount that the nursing homes need to be fully funded. Our system's complicated. We do cost reports. And for those of you that know accounting, pretty common concept. For those of you that are not familiar with it, it makes your eyes glaze over and roll back in your head. But the bottom line is the state looks at the costs that were actually spent for the 3 previous years and then finds averages. And there are some caps on some of the areas that money is spent on. And then that's how the funding is requested to go back into the rates. And at this point, the request is about half of what the estimate is that we will actually need to rebase our nursing homes. In addition to that, our Medicaid system pays about $20 or more less a day than what it actually costs to take care of a resident. How do you stay in business like that? Private pay, their rates are higher, which makes people spend their assets all that more quickly and will need help some point. Medicare pays a little bit better. So if an individual's coming in for a short-term rehab stay and Medicare is helping out, that pays a little bit better. But the bottom line is, it's just not a good business model to have individuals coming into your home that you say, we're going to lose money on every single one of them. But we can't turn people down just because they have financial issues. And some of these people, like I said, they've paid privately and then they've depleted their assets. We have to keep taking care of those in need. That's who we are. That's what Kansas is. But we also need to fund that program so our businesses can stay in business, attract staff, and keep going. When it's appropriate, I'll be happy to stand for questions. And I hope that this has been a little bit of a opening on what long-term care is in Kansas. Thank you.
Thank you, Linda, and we'll hold questions till after the next presentation. And next, as was mentioned, is Rachel Munger, and President and CEO of Leading Age Kansas. Rachel, thank you for coming to committee.
Thank you so much. Thank you for having me. And as you said, I'm with Leading Age Kansas, and we're the state association for nonprofit and faith-based senior care. We have 160 member organizations. They provide the whole array of senior care options. You can see that pretty lengthy list at the top of my written testimony. As nonprofits, our members are run by boards of directors made up of community leaders. Most of our members are in communities of less than 4,000 people, and most of them are standalone, meaning they're not part of a larger chain or health system. I am very thankful to Linda for laying that whole landscape for you guys. We're tag teaming today because it's such a huge subject and a lot of complexities there. So I appreciate her going over that basic landscape and then the closures and risks of more closures that we have in Kansas. You heard Linda talk about the number of total facility closures in Kansas since the pandemic. If you also look at facilities who have managed to remain open but have delicensed and closed portions of their buildings, the number of facilities that have closed or reduced their services at the end of 2022 climbs to 47. If you add the 2 Leading Age Kansas members who started closure at the very beginning of the year, the number climbs to 49, and we're just in January. The majority of the remaining facilities we survey have unofficially shut down wings units due to lack of staff. Often the first thing to go, sadly, are dementia care units because they are so staff intensive. So the issues that we're talking about today are not new, but since 2020, they have overwhelmed our field, almost like a tidal wave. And in these last 3 years, we really haven't been able to get our legs back up underneath us or even really our heads above water. So when we were preparing for this hearing, Linda and I thought it was important to share the data with you all to really attach numbers to a lot of the stories that you've been hearing over these last few years. And because we're such an insanely regulated field, the government collects voluminous amounts of information on us, and that's the source of a lot of the numbers that you're hearing today. There are two aspects of the crisis that we are in that are always intertwined, and that is funding and workforce. So we'll start with some data on financial health. We all know inflation on goods and services, that's everywhere. We're subject to that too. But today we really want to talk about the increase in labor costs that we've seen. Since the start of the pandemic, labor costs in senior care have grown by double digits. It's 22% increase in labor costs for residential care and 24% increase in assisted living. And the worst statistic of all comes from contract labor, also known as temporary healthcare staffing agencies. The annual cost of staffing agency labor has grown by 270%. So when you hear from healthcare providers back home about staffing agencies, that's why. And as you might guess, we cannot stay on this trajectory. The majority of the care we provide is funded by Medicaid. Medicaid does not cover labor cost increase of 22%, let alone 270%. Even when Medicaid payments are supposed to be based on the facility's cost of care, as you heard Linda talk about, it's always years behind. There are caps built into the reimbursement formula, so that past a certain point, the government just doesn't pay you. And that's why even when the legislature does the right thing and fully funds our Medicaid formula, which you guys did last year, and we are so insanely grateful for that, even when you do that, we still tend to bleed money. This past year, KDAD's calculated that for an average facility in this fiscal year, Medicaid payments only covered 90% of the cost of care. So that's a 10% loss on each Medicaid resident every day. That's a lot for a facility to absorb. And that 10% loss is really the best case scenario for many of our members. So that's labor costs. Now we move on to workforce numbers. Our workforce in aging services has shrunk by at least 10%. Our reliance on staffing agency labor has grown by 90%. So I'll say that again, if you hear from providers back home talking about these staffing agencies, that is why. We have a 90% increase in reliance on those agencies with a 270% increase in cost. Our workforce challenges aren't just causing financial issues for providers, they're causing access to care issues, as Linda mentioned as well. You may have heard from your hospitals in your district frustrated about their inability to discharge patients. And the reason why is because our nursing homes aren't taking as many admissions. So to get an idea of how far that issue goes, all of the long-term care associations surveyed our members back in December, and we asked for data on November 2022 admissions data. And you will see on Linda's testimony it's attached to mine some of those results. 60% cited insufficient staffing as the primary reason for declining a new admission. 44% have a waiting list for new admissions. And here's an important number as well. We asked 110 facilities how many admission referrals they turned away in November. And between them, they turned down 1,194 admission referrals from hospitals and other settings in just the month of November. And that's representing about a third of facilities. So if you take that 1,100 and you take it times the other 2/3 of facilities in the state, month over month, and you have tens of thousands of seniors who are being turned away, who are in need of care all over the state of Kansas. So just to quickly sum up a lot of the data I just threw at you, our long-term care system is collapsing under the weight of high costs and low staff. It is hurting the quality and the availability of services in our communities, and we are struggling to find solutions. Like the rest of the country, Kansas is rapidly aging. In the next 10 to 15 years, our 65+ population is going to jump up another 250,000, and it's going to keep rising as the population of our 85+ people increases by triple digits. So Kansans and their families need care. They need it in every part of the state. And at a time when we should be investing in and growing senior care services, senior care options, instead we are contracting at every level. So how can we help? What can we do? None of these things happened overnight. They've been coming for a long time, and there is no magic answer that's going to solve it overnight. But there are some things that we can start doing now, some ways that we can invest in our senior care infrastructure to make sure that we have what we need over these coming years. So as far as this session goes, some things that you can do is making sure our Medicaid reimbursement and our provider costs are fully funded. Our Medicaid formula is flawed. We've talked about that today, but it's what we have right now, and we really cannot afford to fall behind. Staffing agency reform. We know there are serious questions about past proposals we've had that would have limited staffing agency charges, but we have moved on from that. We're letting that go. And what we're asking now from the legislature is help in keeping the labor market more free and fair. And that has to do with buyouts and non-compete clauses that are in staffing agency contracts. So we have nurses and nurse aides who decide to leave the staffing agency. They want to come back and work for us, but they can't oftentimes because the staffing agency points to their non-compete clause they signed in their contract. When agency nurses come to the facility asking to be hired, the facility has to say no because they can't afford the $20,000 to $30,000 buyout that the staffing agency requires in that nurse contract. Our homes cannot compete with staffing agency wages. We just cannot. We can't seem to climb out of that labor cost spiral that's often caused by staffing agency administrative charges. We haven't been able to really get a foothold on that path out of this crisis. It's been a couple years now. What we are asking the legislature is to please help us with at least this one thing. For the nurses and nurse aides who want to return to our buildings and return to our residents, we are asking that those nurses and aides have the freedom to do so. We're asking the legislator help providers that need to hire these nurses and nurse aides to be able to do that without penalty. And last, we are asking you guys to support workforce development and worker-friendly policies. We know there are lots coming through in all kinds of different committees because workforce is an issue everywhere. We know we're not alone in that. So we are asking you to support any of the proposals that will help with training and recruitment of healthcare workers. We also support policies that will help more people enter the workforce and stay in the workforce. And of course, as you'll see this session and then in coming sessions as well, as we try to get an even clearer picture of what's going on in Kansas and in healthcare and in senior care, more proposals that we'll bring to you that we think would make things a little easier for us when it comes to workforce and costs. And before I wrap up, I want to make sure I point out that on my written testimony, you have what's called a Leading Age Kansas Situation Report. It details a lot of the numbers I've given to you, plus many more, including a map of Kansas that has senior care deserts. We have also made a version of this that's broken down the data by each House and Senate district. So if you are interested in what senior care is looking like in your district, just let me know. I'm happy to provide that to you. Thank you very much, Madam Chair, and I'm happy to answer questions.
Rachel, I'm just going to have you stay up there if you don't mind, and we'll start questions with you. So committee, do we have any questions for Rachel? Senator Petty.
Thank you, Madam Chair, and Rachel, as always, it's good to see you. So you've covered a lot of things here. You mentioned towards the end there about the staffing agency reform. So I'm wondering, is there a bill somewhere?
We have one about to be announced. Well, it's been introduced in committee on the House side. We do not have a Senate side yet.
And could you expound on that bill?
Oh, the bill itself? Yeah. Sorry. So what that bill would do, it would do a few things. What it gets after is some of the issues we've seen on staffing agency business practices. So making sure that they are treating those nurses and nurse aides as employees rather than contractors. Because what we are seeing happening is nurses and nurse aides who do not have workers' comp insurance, which is a huge problem both for them and us. Medical malpractice insurance, some of these basics that should be in place for healthcare workers and healthcare providers. It also requires them to not use non-compete and buyout clauses. So we have that freedom of movement in our labor market. It also requires them to register with the state of Kansas so that you're able to track that. And another issue is transparency. So being transparent with us and with the government and taxpayers about how much they are charging our healthcare providers who are receiving Medicare and Medicaid dollars. Because that is a huge issue for taxpayers and the state of Kansas as well.
And what's that House bill number?
I don't have one yet. It's in.
Oh, it's not,
to be
it's
read
it's
in.
going to be read in, okay. Covers
But I
a
will let you
lot of
know.
things there.
does.
That, yeah. Oh, I think I'll just stop there, and I have some questions for Linda, but later. Thank you.
Committee, other questions? Senator Holscher.
Thank you. Rachel, good to see you. Help me through, you talked about how somebody could work for one of these temporary staffing agencies and then later wants to work for you all. So when they're working at the staffing agency, I'm guessing the lure is the higher wages. Then what is it that they are looking for when they decide to come to you all looking for longer-term employment? Is it just the longer-term stability or benefits, or like I said, what is that attraction?
It really depends on the person, but you're right. The attractive part of working at a staffing agency is you can get higher wages. We try as much as we can to compete, but as soon as we raise our wages, the staffing agencies raise their wages and then pass the cost on to us, so we're paying triple anyway. But and also freedom for their schedules, right? Some people, it works better for them to just be able to float and work whenever they want, and you can't really do that if you're working for a facility. So people who come back to work for us, maybe we've been able to be competitive in some way on that wage, and so it works out well for them. We offer benefits. Some people want a more stable schedule. They need it to be more predictable. And then there's just the part of why someone goes into this field in the first place, which is for the people that they care for and the people that they work with and the mission they serve. And some people find that when they leave for the agency, they didn't realize how much that did matter to them. And so they want to come back and they want to be a part of that again.
Committee, other questions for Rachel? Senator Petty.
Rachel, you mentioned benefits. So I guess my question might be, do most of the nursing homes provide benefits like health care, child care?
I cannot speak for, I can speak for our membership.
great.
So, well, just as employers, they need to provide health care insurance. That's generally the case, right? Nowadays, is employers provide benefits. Ours do. We also have even within Leading Age Kansas, we built a healthcare plan for our members to be a part of. We have quite a few lives underneath that, and that was a way for us to help our members attract more employees by offering good healthcare benefits. Child care, we have some people dipping into that. We also have some providers who have child care on their campus. They've worked with their community to host that. Nonprofits have a benefit in that way because they tend to have bigger footprints and provide a bunch of different services, so they have room to do that. As far as those subsidies, some of them have tried to dip into that, but it's pretty cost prohibitive for them as it is for employees. I think there's some other solutions we need to keep searching for in the state of Kansas. We're not the only ones who think that, of trying to find affordable health care. I don't know what that looks like, but our members are certainly interested in it and would like to help more. And I think if we had some more programs available, we could get more of them to participate.
Like Medicaid expansion, that could, it has to impact the employee base that you deal with because of their salaries.
We have not looked into that very much, but based on, well, pre-pandemic, I don't know where their salaries throw them now when it comes to that, but pre-pandemic, they did tend to fall into that in-between place that Medicaid expansion would address.
And when you talked about, so I'm wondering, I mean, because you've seen this big impact in the last 2 years since 20, which there's been lots of things that have occurred driven by COVID. But I'm wondering when it comes to child care, that because of the age of, well, some of the age of your employees, if that doesn't come to be a factor, that the cost of child care becomes too cost prohibitive for them to continue in the job they have.
Yes, I think that has certainly affected a portion of our.
Thanks.
Senator Baumgartner.
Thank you for being here today. I'm looking at some of the data that you provided. You indicate that there are 129 providers. They support just under 5,200 jobs statewide. What we don't see is what are those different jobs? Are you able to provide us with what licensure or credentials are required for the jobs, what a majority of those jobs are? Because it's interesting. We're seeing, when I look at your recommendations, it is rein in price gouging. Price gouging is primarily occurring with the registered nurses as far as healthcare. I've not seen much focus of price gouging on the CNAs or with the LPNs, but I would be happy to to stand corrected on that. But, you indicate what the legislature can do, and that's focus on workforce development and workforce-friendly policies. We've done about all we can as far as fully funding those initial steps to the ladder of healthcare with what's often referred to as Senate Bill 155, but the CTE scholarship, that fully funds any high school student to earn that certified nursing certificate and licensure. We have the Promise Scholarship that has invested $10 million as far as scholarshiping. So what areas aren't being addressed? And again, it gets back to, tried to do some quick math on this, but trying to figure out, so we know for staffing, you have to have registered nurses. You're going to have a lot of additional staff, such as perhaps physical therapists, occupational therapists, and folks that are providing nutrition, so your food service folks. But what licensure and credentials are needed for an average of your 120 some facilities? That's what we're not seeing. And it's been my experience, at least, the long-term care facilities that my in-laws were in prior to their passing, but the facilities within my legislative district, it's very heavy on aides, so that lowest level of the ladder, and that seems to be where that constant churn is. But we don't have any data. We don't have any data about that. And so that would be helpful, particularly when we know that groups such as the Kansas Chamber are looking at changing or reducing the number of hours for people to receive that type of certification, or expanding what their duties would be for that certification, such as administering insulin and so forth. So it'd be very helpful if you could provide that. Also, one of the things that I didn't see in the media or in the materials that were provided is, so with all the closures of the long-term facilities, where did those displaced Kansans go? Thank you, Madam Chair.
Certainly, we can dig back into the data and get you a lot of the numbers you're asking for. Linda and I will work on that, and we'll get you some even more numbers for you to look at. As far as where do people go, it's a very, very good question. I don't know that we have the answer. We don't have a way to track, where people ultimately end up. We know our side of things, of how many people we are turning away. I do know, and you can see that in my written as well. We also know that home health are having the same problems as far as workforce shortages and labor costs. So we know that they are also struggling. And just hearing from hospitals, we know some people are just staying in the hospital until they find the next place. So I'm sorry I don't have the answer for you. I can only give the data from our end of things of those types of numbers.
Thank you, Madam Chair. I would challenge that just a little bit. When a long-term care facility closes, they have all of that contact information for those individuals. They know family members, so there would be a way to track that. And there should be a way, if an individual comes and they are looking for a place to put mom or to put our aunt, all that information is collected up front. At least that's been my experience with long-term care facilities. I don't know of a hospital that is allowing an individual, a patient, to stay when they are no longer in need of medical care. So I challenge that just a little bit, Madam Chair. Thank you.
I see what you're saying and asking. I think I will still go back to the fact that we have no way of actually collecting or compiling that in a way like that way. I think when I've talked to some of our members who have closed, sometimes you can find some beds here and there in a nearby county. Some people have to go quite a bit of ways away to find a spot, and I think that's the source of a lot of our concerns as well. Like when you see that senior care desert map is once you move someone out of their community and they're farther and farther away from their family as well, they don't get visited as much. They don't have that advocate as much either, and it's even further isolating for someone in a nursing home. It's very difficult on residents and families.
Sorry, Madam Chair, just one final comment. I don't want my questions to be perceived as I'm not supportive. I think historically, particularly with when COVID hit, I think that I was very outspoken and supportive. I think that our long-term care facilities took the brunt, not receiving appropriate safety equipment when it was being stockpiled and stored by our hospitals. I think the one thing that I haven't heard, but I did get here a little bit late, but I think that we all must keep in mind is our long-term care facilities, particularly our nursing homes. That is the home for these Kansans. That is their home. And when we talk about affordable housing in Kansas, for some reason, no one ever mentions, it's never included in the conversation, that affordable housing also includes assisted living facilities and what we would consider our traditional nursing home facilities. Families are left scrambling just to protect the best interests of our elderly. And they are Kansas residents. And that was what I think concerned me the most during the early throes of COVID is I didn't believe that KDADS or the Kansas Department of Health was treating those individuals with the respect they deserve, because those are Kansans that needed that assistance while they lived and have been residents of this great state. So I didn't want it to be perceived that I'm not supportive of the good work that is done. I had many, many students when I taught at the high school that that was their entrance into healthcare, was working at one of the local facilities there in Lewisburg. It was very meaningful, even when they weren't on shift. Some of our junior and senior high school gals would go and fix their hair and do their nails and be there with a little gift if it was a birthday or anniversary. And that is how we bridge that support, is including our younger folks in helping care for our elderly. So thank you, Madam Chair.
Appreciate that. Thank you so much.
Committee, do we have other questions for Rachel? I know we have several for Linda. Okay, Rachel, I just have a couple of you for you before we go on to Linda. You mentioned the Medicaid formula. Can you tell us what that is?
It is something set up in statute and reg. It is done in conjunction with state and federal through KDADS and CMS. I will let Linda tackle some more of this as well because she's so much better at it than me. But it is a way for our particular Medicaid formula in Kansas has cost reports. So we capture everything a nursing home spends in a year, and it is detailed. We even submit balance sheets. I mean, it's all in there. So anyone who threatens us with transparency, we're like, okay, you literally know everything about us. So the state of Kansas funnels all of that cost report information into a formula that is very complicated, but basically is meant to spit out on the other end a fair-ish reimbursement. But it's also based on the last 3 years of your cost reports, not just one, so it's always behind. And then, of course, in order to encourage efficiency, they put caps in it, and that's where you get us caught up in when we have these big increases in labor costs, even if it's in our cost report as a cost we have, the government still doesn't pay us for it because it goes over the caps. It's just a lot, and I probably left out 1 million things, but that's basically.
Thank you for that. That's for our listeners here. So I'm hearing about aides and, various levels of nursing that are working in the centers. And however, we know that you mentioned there's a staffing shortage, and I guess the shortage is down by about 10%. Is that right? Do you have any of your employees that you pay minimum wage or below?
No on minimum wage, for sure, because that's the minimum wage. But I guess I'm just going to say I don't know, because I'm not going to try and guess on what it was pre-pandemic, but I know that now we are absolutely paying premium wages, which many people are like, good, you should. We agree. But the problem is not having the funding to back it up, or not having the resources we need to make that long term. We've survived on federal emergency cash that in some state and through the state as well, some of those federal pots of money were given to us to help us support staffing. That happened last year as well, to help us do some retention bonuses, things like that. And of course, those are all audited and reported, everything we spent on those. But that's very short. And now we're at this cliff, right, of, okay, we know this emergency cash is not going to keep coming anymore. So how do we keep these wages going? And I think that's why you've seen more closures. You've seen much more risk of closure, because we're really not sure from a financial standpoint what a year from now is going to look like, knowing we won't have these extra supports.
So if you're aware then, if a single adult makes at least minimum wage and works 30 hours a week, they're qualified for a plan on healthcare.gov that's zero premium. So when you mentioned Medicaid expansion, that was kind of a puzzlement to me. Okay, we're going to go on to the questions for Linda. And we'll begin with Senator O'Shea.
Thank you, Madam Chair. Thank you both for all you do and for being here. I have been looking into a little bit of lately of, are there child care centers that are attached to aging services, and how might we use that as a model to share resources like food or human resources, marketing, finances? So I just encourage for us to keep thinking innovatively as a state on that. You had mentioned the state fully funding. So I think my question has been answered now, that it's the Medicare, and that why it's sometimes not fully funded because it's based on past years. Anyhow, I think I have a better picture of that. Is there anything else that the state, and you mentioned the governor's budget, other than Medicaid, Medicare, that the state is expected to fund in terms of aging services, nursing homes?
Madam Chair, to the first point with the child care, we do have a member down in Emporia that has a type of home, if you'll refer to your types of different facilities, it's called a Home Plus, and that is 12 beds or less, and they are integrating childcare into their buildings. And when they are building new Home Plus in different communities, childcare is a part of that. It's Sunflower Care Homes, and Clint Arndt and his wife, whose first name escapes me, is a DO, and they are really committed to bringing that community in, not only to help the staff, but that intergenerational for our elders is phenomenal. As far as the funding goes, yes, Medicaid is underfunded. We do have a federal match that helps a little bit. Right now, it's elevated because we're still in public health emergency. But as Rachel mentioned, those extra dollars are going to start slipping away very, very quickly, but our costs are not. The cost of a nurse aide or an LPN or an RN, we've talked about a little bit, but we haven't talked about laundry, housekeeping, maintenance, just barely touched on dietary, social services, activities. When you're competing with the Taco Bell down the street, who's paying $15 an hour, you have to have something more. So sometimes it is just the dollars and cents. Sometimes it's helping them navigate that healthcare system, that, hey, if you come to work for us, you know, this is what your wage is, this is how many hours you need to work. Let's get you hooked up with a navigator to get you on the exchange so that you can have health insurance. Because a lot of what's happening is that people don't know what their resources are, and whether that's the employee or whether it's the senior or their family members. So to your point, Senator O'Shea, what I think Kansas can do to help that situation is to, you know, you're working on broadband, you're working on access to information, and just keeping that up, but also funding those area agencies on aging and the different senior support services so that people do have access to information and can navigate through the system. Because I don't know if you've gone out on some of those websites, but it's not intuitive. You really need somebody to help you through.
Can you tell us what percentage of the patients or members in the homes are paid for by Medicaid?
Madam Chair, at the last numbers that I looked at showed over 50%. Some are much higher, some are lower, but at least 50% on an average. We are going to be talking about legislation that incentivizes and helps to repay those buildings that take a higher percentage of Medicaid. As I mentioned, there's at least $20 a day loss when you have a Medicaid resident. And if you don't have those private pay residents or private insurance or Medicare to help keep the ship floating, but yet you're taking a high percentage of Medicaid, let's help those folks out so that our Medicaid recipients can be in good facilities and get good care and have a good quality of life.
Would you agree that there is less incentive to purchase a long-term care private insurance policy now because one can go on to Medicaid?
I would say that's a philosophical point of view, and that depends on so many things. What are your assets? What are you trying to protect for the future? How can we incentivize people to buy long-term care insurance? And maybe that's carving out, you know, what they've paid in premiums as to what their assets can be protected, if you will, because they've stayed off the state's rolls for additional time. Representative Landwehr on the House side has a lot of knowledge about long-term care insurance and is quite passionate about it. And I'm afraid I would have to defer to her for specifics on how to, you know, really dig in and make that work.
That's all right. We share the same knowledge. She and I are both former agent. Well, I'm an agent. She's a former agent, but work with long-term care. And we are just seeing more and more people say, well, in time, it's going to use up my assets anyway. And then I go on to Medicaid. So don't see why I need long-term care. Thank you for that. And then Senator Blasey.
Thank you, Madam Chair. One of the facilities you had on the map recently closed in my community, and I was curious on state fines. So when the state comes in, and obviously you have staff shortages, you might have numerous other issues due to the stringent regulations, and the facility is fined. Are we finding, as a state, working as a partner with these facilities in terms of working through some of the problems that need to be addressed to ensure that the patients are safe? Or is it just kind of overburdensome where we're fining people and then they end up having to close, like the one in my community, because of a fine? It's just financially, they're already stressed, and then they get fined for something. I don't know the specifics of this particular case, but then they can't recover, and then they have to close, and then next thing you know, 30 people are homeless. So my question is the state working as a partner along our facilities, or are we in the way?
Thank you for that question, Senator. That brings up a very good point. Our survey agency with KDADS is basically a contractor with the Centers for Medicare and Medicaid. So they have to come into our buildings, our nursing homes, and enforce federal rules and state rules. And part of that assignment, they have very specific tasks that they are told to do. They have, if you see this, you should do that. There is not time, nor are there resources built in to train, mentor, counsel, help solve problems. One of the solutions that we see is, instead of having just the stick, having accreditation, like the Joint Commission that the hospitals use, where part of their role is not to come in and tell you what's wrong and give you a fine for it, but to help you do your own quality measures to see where you have weaknesses and then give you solutions to help you get better. We all need help getting better, but when we're constantly just torn down and fined and torn down and fined, and that's not to berate the surveyors. They have a job to do. They see what they see. Could it be better? Yes. But they, as a state agency, can't pay what the private market does for registered nurses or LPNs. So they're short on staff. So I can't say that we should look to the state to solve that problem, but I would say looking at accreditation with perhaps a partnership with the state to help pay for that, because Joint Commission is not an inexpensive process, but it is a tried and true reliable method of improving quality.
Linda and Rachel, thank you both for being here, and I'm afraid we're out of time. So committee, we are adjourned.